Dr. Mohan Bhuvaneswaran. Dr. Mohan Bhuvaneswaran is a postgraduate from GDC Chennai, and he practices in Chennai exclusively restorative and cosmetic dentistry. He is the General Secretary of the Indian Association of Conservative Dentistry and Endodontics and President of the American Board of Cosmetic and Aesthetic Dentistry. Today he is going to talk to us about a very, very important topic that is called managing intraoral repair of composite, ceramics, and zirconia chips and cracks and fractures. Now, these are things that happens to so many people, but not able to address it and do the needful. So, Dr. Mohan, 3:30 sharp. Welcome aboard.
Yes, sir. Am I audible?
Yes, very much.
Thank you so much for that kind introduction, sir. A very good afternoon to all the audience, and the great attempt of the E-Famdent conference by Dr. Anil Arora and Dr. Krishnasamy for their beautiful visionary project. Thank you so much for giving me this opportunity to talk on this topic today, on the big topic you told. I'm going to talk for the next 30 to 35 minutes, right? It's more of a practical topic. So after that, I would like to take some questions if time permits. So I will keep my lecture as short as possible, giving the clinical data about this one thing, which we come across often in our practice. Actually, when Dr. Anil Arora asked me topic, I told him, you tell me, sir, and I never expected he will give me this topic, but still I told him, yes, I'm going to do this, and I learned a lot. So this afternoon, we are starting with failure. Unless we know the reasons for failure, success cannot come like that. So it is important that we understand the failures also that are related with our treatment so that we are able to do successfully our practice and what we are doing. One such procedure in dentistry is the indirect restorations. Of course, we do direct restorations also. We're going to cover up the composites and the ceramic fractures, chips, and the cracks. So these are quite common. I will not tell that it is uncommon at all. At least once in a day, we come across a patient who's come with a fractured ceramic. Probably he or she will not complain about that because it doesn't bother them at all. Unless and otherwise, a metal is exposed and the patient tells, doctor, what is that black thing? Is a cavity. No, we tell them the underlying metal is exposed. I don't know for what reasons. We'll just smooth it and the patient doesn't bother much. But such a thing would not happen in an all ceramic restoration. I'm going to discuss that in detail actually. So what do we do when we see an all ceramic restoration that is just leave it off or wait for the failure to happen, or what are we going to do? That is the question 2. And the next thing is the direct restorative. Composites will also fracture sometimes if not done properly. That is number 1. And also the occlusal forces are not taken into consideration. So first let's finish off composites, because composite is very minimal. Whereas ceramics, we have variety of ceramics. So I'll finish off composites first, composite fracture. So understanding composite fracture is very, very important. So I told you, right? It's not that I've done a composite with all the best of my abilities and why did it fail? Or it might be another reason, patient coming back, doc, I got this done with somebody else, but now I'm not able to go there, it's fractured, or also I don't want to go there, can you attend? So without even understanding the failure, if we try to attempt to replace or repair, then it's not going to work out. So my dear audience, please keep it into consideration that first, I'm going to give this in summary. Anyway, first is to find out the reason for failure. You need to 100% know why it is failed. So there are 2 categories actually. Debonded restoration. I'm going to talk about debonded restoration because debonding could happen because properly bonding has not happened. The topic is fractured restoration, or you have a crack. So why does a fracture happen is that you saw it in the posteriors. It is probably because we have not followed the principles of restorative dentistry. The 2 main principles of restorative dentistry is resistance and retention. See, people always mistake bonding agent for one thing. Bonding agent was introduced to improve the retention and not the seal. People feel that it gets sealed and everything is done. No, it improves the retention form. That's all. It doesn't form a seal. So I can stick something together. So that is what is the job of the bonding agent. So if you do not have the right retention form, the bonding surface is not big enough, or the resistance form. Resistance form is the shape of the cavity which can withstand the forces which would break the restoration or the 2 structures. So in a posterior, if your class 2, that is very, very common, your class 2 proximal box will fail. So that means the resistance form is lost. That's why it's broken. So there I would like to, when the question comes, if I'm going to repair or redo, definitely in such a situation I'll want to redo. I'm not going to repair. I'm not going to take a bonding agent, put the, no, it's not going to work out that way. I'm going to entirely remove. So first is that knowing the reason for failure, that is going to be the first key to success. Then making the decision if you're going to repair or replace. So please understand, first you have to find out the reason for failure, then whether you're going to replace or repair is the next question that you have to answer, that is right in front of you. Such a situation, I will definitely redo the entire restoration. Then I would look, such a situation happens in posterior. The next part would be in an anterior. In an anterior, most commonly is the loss of anterior guidance. So I would check all the occlusal interferences that's happening with the restoration, probably in a class 4. In a class 3 also nothing much happens. Only a class 4 restorative in the anterior would cause such cracks or fractures. So I would evaluate the anterior guidance, sorry, and how much of occlusal interferences are there, rectify them, and then proceed with the repair of the restoration. So my clinical judgment of repair of the restoration is very important, because repair is going to be very simple. When will I repair? Next is that when I know that the earlier restoration is solid, good, I just have to do some repair work, will solve the problem, then I'll repair. If the earlier restoration is not up to the mark, then it's wiser to tell the patient, see that restoration is not up to the mark, it's better we redo the entire restoration rather than touching it up. So if it is a smaller one, the entire restoration is good, then we would think about repairing. So we are going to talk about only repair of the restoration. First thing is that making sure that there are no occlusal interferences in composite. Please remember, isolation is very important. If isolation is not there, then probably the restoration debond, but we are not talking about such a situation here. We are talking about a situation which is fractured. So you make sure that occlusal interferences are not there, and then you go ahead with a repair. I also have a small video, I'll play it for you. So first you give a long bevel. Generally what happens is that people do it with a micromotor also, that also more preferable. The only thing, I don't want any contaminants there, so isolate it beautifully, then use an adhesive. Any adhesive would be, you don't have to etch actually, because generally after the beveling is given, what will happen is that the salivary pellicles will go off, so you don't have to actually do the etching part of it. Etching with phosphoric acid will generally remove the salivary pellicle, so we don't have to do that. Then you apply the adhesive. The adhesive can be a universal adhesive or a 5th generation adhesive. Then you place the composite, finish it, and polish it. That's all. That is how it goes with a composite. So first is to identify the reason for failure, make sure such a reason would not happen in our restoration again, and again do it off. Now here, make sure you are able to get the same shade, because you are, if it is not done by you, you have to make sure that the material what you have should actually match. So what you do is that before you do such a procedure, take, if you feel it's A2, take a little bit of A2, put it there, and make sure that this is the same composite what you are seeing. Fine. So look at this. We give it a small bevel here. This is the model what you're seeing. This bevel is given, and then make sure that you beautifully clean it, isolate it completely. It's very important, again, isolation, because for adhesive application, isolation is very important. I'm using an universal adhesive here. I'm just applying it there, and then I'm polymering it, and then I would place the composite, finish it, and polish it. So this is how we do the repair for a composite. If there is a small crack line or crease line, which is an incidental finding and not a patient complaint, then I would simply bevel in the crack line, seal it off, clean it with a bonding agent, and then apply the composite and proceed with the repair. Very permanent with the composite. So that is to do with the composites. Coming on to ceramic, there are wide variety of ceramics today. We start with metal ceramics, glass ceramics, and oxide ceramics. So metal ceramics is PFM, crowns, bridges, which is common today also. Day-to-day practice, many of them still do PFMs, and long span bridges, inevitably, we are also forced to do only metal ceramic crowns. And coming to glass ceramics, that is the Emax or Empress, more of an aesthetic restoration. People do it in the anterior region. And coming on to the posterior region, or sometimes even on an anterior bridge, it is oxide ceramics. I would like to tell 2 things before I proceed here. One is the layering technique and the staining technique. Fine. Earlier, zirconia, we know zirconia is like a metal. It's a metal actually. In a periodic table, it's a transitional metal. So what happens is that earlier people used to layer it. There was an interface. So you know that happens to the metal also, the metal and the ceramic, there is always an interface. In metal, it was, you have a lot of literature, which I can also give you, which tells that the metal and ceramic can bond better than the zirconia and the ceramic. So this was very, very poor. The retention was very, very poor with zirconia and the ceramic. So nowadays it's only full contour zirconia. So if a zirconia fractures, mostly it is into two halves, or it is at the connector zone in a bridge. So the amount of replacement of zirconia is more rather than the repair of zirconia. I don't think you will ever see a patient with a cusp fractured in a zirconia crown or a bridge. That is not going to happen with zirconia because it is a monolithic crown. If somebody is layered it in the anterior, that comes in an anterior, then probably we'll talk about repair, not a replacement. Whereas this is again the possibility with glass ceramics also, like Emax and Empress. Always the interface is the weakest part. So probably if they're breaking, they will break at the interface and not at the exact cusp or the contour of the crown. So the same rule in metals, people will complain that the metal is visible. In glass ceramic, they will not, because they already feel that it is all white in color, so they don't know probably it's chipped or not chipped. Only if it breaks into half, the patient would report to us. And why am I talking about this? When we see it incidentally, if you want to extend the span of the restorative work what you have done, then it is better we repair the restoration what you've done. Incidentally, I see a cusp is fractured or the layering portion is come out. All this would come in relation to aesthetics. People would not like a broken tooth in an anterior or an exposed metal in the anterior and post they tell chalta, it's okay, no problem, forget it. So coming on to the fractures, that can be simple or complex. Probably this article was written related to the porcelain fused to metal, but it also implies to us the layering technique. If you do not want layering, then we do the staining technique. That's what I wanted to tell you. So in layering technique, what happens is that it's simple if the underlying substrate is not visible, and it is complex if the underlying substrate is exposed. So in a PFM, the underlying metal is exposed, then it becomes complex. Otherwise, it's very, very simple. What you have to do is give a bevel and then put the composite and then do an intraoral repair. Fine. And then complex, we need to understand, again, please understand why the failure has happened. Probably the metal ceramic interface was not good. There was a design which was improper, inadequate framework, and flexural fatigue. That's what technically we keep talking, but clinically we need to find out if it is related to the occlusal factors or if it is related to the flaw in the laboratory. 99%, please, I request all of them who are listening here that choosing a right laboratory is very, very important, because nothing is seen behind the screens. The patient, you can't tell the patient, go to that laboratory did it you. We shoulder all the responsibilities. So that part, if there is a huge mistake, then it is a fault of us and not of the patient, because we have not chosen the right laboratory which uses quality material. So please make sure that you use a quality laboratory which delivers you quality products, and most of the fractures are related to the intraoral reasons and not to the laboratory reason. That way we will be able to avoid all these things. So what are the causes? I told you, right? Causes of fracture of veneering porcelain. Please, remember what I told you in the beginning. It is the veneering porcelain. So we have a substrate, on top of that we veneer it. So that veneering ceramic will only chip off. If it is a monolithic crown is the crown entirely made up of Emax, entirely made up of Empress, or entirely made up of zirconia. That breaking or chipping out is going to be a rare possibility, but crack lines are quite a possibility. So if at all my Emax breaks, it would break into half. That means either the resistance form of the material is not there, or the occlusal interference is so much that the load is just shift them off. So in that case, it is only the replacement. So the decision between repair and replacement is also another critical factor in determining the success of a repair work. So this is more of theoretical part of it. Why all can the veneering porcelain do? So this veneering is totally today related to the anterior work only. So when I'm doing a zirconia bridge, the monolithic will not give that much. Today we talk about multi-blocks and so many things, but the monolithic will not give us that much of aesthetic. So people always, even I instruct my lab, don't stain, please veneer it. So there is a mismatch in coefficient of thermal expansion, thermal conductivity, or the phases in which the glass and the zirconia, the glass and the metal could go. Aging process, framework design is a failure, or the veneering method itself is a failure. So all these could be a failure from the laboratory side in the mismatch. So in our side, the occlusal factor. So please make sure that you undiagnose the underlying etiology, check for all the occlusal interferences which I've been talking from the beginning, and also check for the parafunctional habit. See, because once the patient will accept, see, the patient is the main person in our office. So once failure patient would accept, so you repair it, generally people will not accept. See, psychologically, even we buy something and it gets repaired, it's okay, we know that it's already repaired, so we feel always that the life is coming down. So if the patient gets that feeling, then it's going to fracture again, then that will impact on our practice. So please make sure that you understand, and next time such a thing doesn't happen. So one repair anybody would accept, but not beyond that. So repair or replace is the next question we need to answer. So I'm going to give you something here. So there would be a fracture happening either in the occlusal aspect, labial aspect, proximal aspect, incisal and lingual. So where all can I repair, where all can I have to replace is simple. I'm just putting this chart. If you want, you can take a screenshot of it. All those appearing in green can be repaired intraorally. Please, labial, lingual, incisal, yes, I'm 100% sure, I'm confident that would happen. Occlusal, maybe sometimes I would do the repair, but not always, depending on understanding the occlusal forces. But proximal, never ever will I do the repair work, because 100% is going to fracture. So I will either redo it or take the crown in full, give it to the laboratory, get it done and put it on the patient's mouth. So please remember, the green things what you see here are favorable for the repair, and the red is 100% no, yellow is maybe. I'll show you a picture, you'll understand. Look at this. This patient has come with a fractured ceramic veneering ceramic in the metal ceramic crown, which was done to her, and you can also see that the metal is failed. So the actually otherwise everything seems to be good for this patient. So what am I going to do? So first, how do I evaluate is that this is a functional cusp. The functional cusp, the load is obviously more. So I need to check the occlusion, if there is at all any clearance or what is impacted. So obviously the reason for this is the quality crown done by a quality laboratory. I'd have no doubts in that at all. But probably there is a discrepancy in the fit. That is why the metal is also chipped up. You can easily see what is happening there. So once such a thing is there, I want to generally replace it, because I don't know what all is gone inside and caused the defects. If it is a tight fitting without any tooth exposure, then we would take up this case for a repair after understanding the underlying occlusal interferences. So options for ceramic repair is that, as I told you, I remove it in full if there is a possibility. So I use these crown removers and remove them in full and send it to the laboratory with the model, and make sure that the lab does the necessary surface treatment, and then proceed with the ceramics, or do an intraoral ceramic repair, which is what I'm going to discuss. So please remember, I'm going to tell this in summary. First is the diagnosis, that you found out the reason why it is happening, then the decision that you've made, whether you're going to repair or replace, then how you're going to put the repair work. So the repair flow is, first is surface treatment, and the next is going to be addition of coupling agent. So we'll see what all the possibilities of surface treatment. So generally, people do not want to invest on heavy material. So everybody has a diamond burr. So on a larger perspective, 75% of them just roughen it with the diamond burrs, and others also suggest with an acid etching, probably with some restrictions. The grid blasting is done intraoral. I'm going to discuss about that, and sandblasting, which goes to the laboratory. So obviously, when you could do an intraoral blaster, which is going to be very, very good, but mandatory is using a diamond burr, roughening the surface, and then in addition, if you're going to etch it, that would be very, very, very good. So coming on to the intraoral blasters, there are quite a variety of intraoral blasters. This is one cheap intraoral blaster which is available here in our country. All you have to do is connect this to the aerator. This is not very expensive. It's somewhere around 12,000 or 13,000 rupees. Very, very effective. You see this, it has two bottles in them. One bottle will host the aluminum oxide, aluminum trioxide, and the other bottle for the glass. Aluminum is obviously for metals and zirconia. Glass is for glass ceramic. So you have 50 microns of aluminum trioxide and glass particles, which could be filled in the separate boxes, and then you can do that. I'm going to show you a small video of this. Let's look at this blaster and the powder. It is more conducive for bonding. But only thing is that, please remember, you saw how messy it is. So doing this intraorally is going to be a challenge. So always people talk about the disadvantages on air abrasion. 100% I would recommend only with rubber dam. So please apply rubber dam 100%. Then you do the air abrasion. Then you proceed further with the procedures, whatever we are going to recommend. So please understand the surface treatment has to be done, and then you'll have to proceed with a coupling agent. So this is a small gist. Probably you can, anybody who wants to take a screenshot can take a screenshot of this, wherein a summary of the surface treatment that is available for metal, felpathic ceramic, Emax, Empress, and then the zirconia, and then the composite. Each one would require either of the surface roughening with a diamond burr, and then probably one of these air abrasives. Air abrasive is very effective. I'm not totally against it, but once used properly, it can be very, very effective for us. Then now it's like etching, and then what you do is that put an adhesive to it. Adhesive, we don't call it an adhesive here because we call it an coupling agent. Okay, please call it as a coupling agent. So we have plenty of restorative materials which are being discussed now. Obviously glass ceramics, that is Empress and Emax, the regular metal ceramics, and the oxide ceramics, which is the zirconium oxide. So every one would require a different coupling agent. So silane methacrylate is always related with glass ceramics, Empress and Emax, and then oxides, that is zirconium oxide and base metals, will require phosphoric methacrylate. So these methacrylates are very important, like a bonding agent. After your surface treatment is over, you apply onto them and then you put your composite on top of it. So this is very, very important so that we could able to do that. Now the current concept is that probably 3M introduced all-in-one, that is our tooth bonding and metal bonding and restoration bonding together, but that did not work. So everybody today uses all-in-one, and a classical example what I love and what I use is monobond. Monobond N from Ivoclar Viverdent is a very, very nice agent which could be used for any of the coupling agent for any of the restorative materials. Now coming on to the reason why they are very, very successful is one magic resin which we call in dentistry is a MDP, 10-methyloxide dicyl dihydrogen phosphate, which is a quick, it's like a quick fix. It's a magic resin. It could stick to anything. So the addition of MDPs made the whole difference and the success rate and the repair work what we do. So generally I'm talking about a metal ceramic. The same rule applies for the all ceramic also, but the only thing is that I would not be using any opaquing agents to mask the metal surface which is exposed. So first thing, as I told you, I'm going to also show you a video. I'm going to use an good aerator burr and give a long bevel and then use this acid. Actually, coming on to the acid, this hydrofluoric acid which is used extraorally, nobody uses this intraorally. If you are using it intraorally, please use it under rubber dam, because this is quite poisonous and also detrimental to the dentine. So never use them offhandedly intraorally. Then we apply, once the surface treatment is over, then what we apply is the monobond. Monobond is a coupling agent which could be applied for both metal ceramics, metals, zirconia, and the glass ceramics. Then we apply a bonding agent layer, polymerize it, and then proceed with the composite placement. So that is with regard to any of the surface treatment. So first is understanding the failure, then making the decision repair or replace, then doing the surface treatment, and then doing the adhesive or the coupling agent. Now zirconia, as I told you, zirconia is very, very problematic. See, from the beginning, zirconia could not bond to anything. That was the reason why the veneering of the zirconia was stopped. People were no longer, if any lab you ask, they would directly give us only the monolithic zirconia. That's why the aesthetics level with the zirconia is coming down. Though today translucent blocks have come and also multi-layered blocks have come, there is always an issue within zirconia if not layered. So layered zirconia will fracture at the interface, but a zirconia as such, a crack is developing, that means it is 100% leading to fracture. So if I see, if I've seen a restoration, what I've done or what somebody else has done, I would strongly suggest them to replace a restoration rather than playing around with the zirconia restoration. Anything else I would love to repair, but not zirconia, because the bonding is always a big failure. So there were a lot of studies that was done with the zirconia bonding, and they found out that these are quite, if you ask me, these are all quite impractical or literature based. Silica coating can be slightly practical, but selective infiltration technique and hot etch solution with a special solution which in the study they have designed, it's more, that's why I put that red, it's more of theoretical point of view. So I'm not going to discuss more on that, but silica coating, what they have told is that it's like the air blasting, right? You apply silica, that would definitely improve. That's what Frank Barrer et al. They told that when sandblasted, of course, with the rubber dam with the silica obviously penetrates into the zirconium porosities, and that forms a good base for the adhesive to stick on or the coupling agent to stick on. So that is why zirconia fracture generally people will not want to do a mini repair with the zirconia. So what they'll do is that they'll apply the silica, make sure that the substrate becomes better, and then they would proceed further with the repair of the zirconia. So please, when it comes to zirconia, let the red bell ring to you that am I going to repair this seriously? Then silane is also used on top of that, so that it becomes a good bonding adhesive for the bonding substrate for the repair work what you're going to do. There are a lot of repair kits that are available in the market. I'm not going to ask you to buy the repair kits. It's like a refill packet you can buy. I think most of us would already have the coupling agents which we use for the all ceramic bonding, right? When I'm luting a veneer or something, I already need these coupling agents. So I already have in stock of these coupling agents. So I'm not going to invest again on these coupling agents or the composite which comes along with the kit. The one thing which I would ask you to buy is very important is the colors. So every company gives you colors. Every company gives you colors. So please try to buy the colors, which is very important for us for the repair work. So first, the most important colors would be white and yellow. Why? I'm going to tell you why they are important. Please do not confuse white with the opaquer. Opaquer is totally different. Fine. What you see here is the opaquing agent. The opaquing agent is an opaquer which is used for metal ceramics in the laboratory is now available for us here in the chair side. So we have these direct opaque agents which would mask metal beautifully. So please understand the difference between the white color and the opaquing agent. The opaquing agent actually masks the exposed metal surfaces, and then also the metal post or intensive discoloration. So generally I don't push them for discoloration because it makes the composite very, very white. So I actually use them for masking the metal post or the masking the metal surfaces. This doesn't come into play when you're doing an all ceramic repair work. So please keep in mind this opaquer is used only for metal ceramic work. Now, I told you about colors, right? Colors are tints. I told you also it's better to have a white color and a yellow color. White color would help for the composites when you playing with discoloration. Now I'm going to tell you a small clinical trip which would be really, really helpful with the use of yellow color. Now look at this video. I'm going to explain to you about the is metal ceramic which got chipped off there. You see the chipping there. So this is a step-by-step protocol what you're seeing here. After isolation, I'm trying to give a good bevel there. You see that? A good bevel. Fine. A long bevel is what we actually keep talking about. And the long bevel, what you see is done. And then etching is done. See, this etching actually is done to make sure that we remove any surface debris. Once it is removed, that is the coupling agent. So please remember that we do the surface treatment first and then the coupling agent. After this, it is important that we wait for 1 minute. So please remember that you wait for 1 minute after the coupling agent. I'm going to play it again. Now look at this. I'm applying the coupling agent. So after application of coupling agent, which is used for both metal and non-metallic ceramics, you wait for 1 minute and then do not polymerize it. Please remember, you do not polymerize it. The next step would be application of the adhesive. I'm applying the adhesive. Then I will wait, allow the adhesive to act. Then I would remove all the excess adhesive and then I would polymerize. Do you see that? So after this, I would now the next step is that you see this opaque. Can you see that? So the metal portion alone, I will apply the opaque. So what happens? The metal gets masked off. So the metal gets masked off, and then you see that white layer, right? You see the white layer which I'm applying. So what happens is the metal layer just gets exposed. Exposed layer gets off. Fine. Now somehow I feel that this white is too white so that it will be visible to the composite. You see in the cervical portion is going to be very, very thin. In the incisal it's so very different, but in the cervical it's very, very thin. So what I will do is that one additional step is my own innovation. I would tell that where I apply after this, I would polymerize it. After this application, you see that I'm using the cannula, I polymerize it. And after this, I would apply the yellow color. And yellow color will mask the whiteness of the opaquer and make it more like a dentine color. So what happens is that when we have the dentine color, then the composite what we place is looks very, very beautiful. So after this, applying that yellow color, can you see that I'm applying the yellow color? So you see the intensity of the whiteness is gone, and then I polymerize it. Then I place my composite on top of that. So generally this is the rule is followed for everything. And only thing is that the difference between metal ceramic and the all ceramic repair work would be the use of these masking agents. So in an all ceramic, I don't have to use any masking agents because it's already tooth colored. I don't have to mask any underlying discoloration. So only difference is going to be not using the masking agent. So that is the result what you see after the completion of the repair work. You see it's completely blended, polished well. So please don't think that repair is a failure. No, please, I'm not conveying that at all. Identifying correctly is what is more important rather than doing. That's why I showed a clinical case rather than a model. You see that it is perfectly blended, right? This is what is important. Even in aesthetic dentistry, we tell that when your work blends off completely with the existing whatever it is, that means it is successful. That's what we call bioemulation. Nobody is able to find out what has happened there. So here nobody can find out what has happened there. That's all. So that means this is going to work, provided we have understood the reason for failure and eliminated the same. Now I'll give a small quick example of an all ceramic fracture. In an all ceramic chip that has happened. This chip, what I do is that 100% use a rubber dam to isolate. Give all cases, please remember that you give a bevel with a burr. Fine, you give a beautiful bevel, and then the next thing is the decision what you make. Fine, everything, rule number one is going to be giving a bevel with a air rotor handpiece. Whether you're going to etch or whether you're going to use an air blaster. I don't know how many has that air blaster because that's an extra investment. Not many would have that. We would have that for using it for restorative work also. We use it for restorative work to remove hypoplastic enamel, all those things. But how many in a general scale would have that is a question. So we are not forcing that everybody has to have an air blaster. You can either use that's why in the video I use the regular orthophosphoric acid, which is used for tooth etching. Or if you could do a good rubber dam isolation, probably you can think about something shown in this picture, that is the hydrofluoric acid. Hydrofluoric acid, please remember, it is poisonous. Be cautious when using intraorally. If I'm using it, I would immediately wipe it off with cotton. I will not even wash it because if I wash it, it would spread all over. So I would immediately wipe it off with a cotton and then wash and then apply the bonding agent. Got it? And the coupling agent and the bonding agent. So please remember, it's very, very simple. You give a surface bevel, then you do the etching or the sandblasting stuff, and then you apply the coupling agent, then the bonding agent for the composite. All work is done, repair is done with only composites. And if it's all ceramic, I would strongly prefer Empress Direct composite. That would exactly match. Actually, Empress Direct is a direct composite that is available for the intraoral repair work. So Empress Direct, that is a replacement of the filler particles of the glass ceramics are done in the Empress Direct. So the look and feel is beautiful like Emax itself. So I would strongly suggest that composite, polymerize it and finish it and polish it up. So that is the story of the repair. So in summary, you can also take up that screenshot of this. In summary, I would tell that these are the recommendations. I put it in a table. Intraoral repair of fractured ceramic according to the material and composition. You have the glass ceramics, you have the oxide ceramics, you have the porcelain fused metal, and composites. It's always, we know that we're going to roughen the surface, put the bonding agent and put the composite. So please remember, hydrofluoric acid, air abrasion. The choice is yours. If you have an air abrasive unit, please go ahead under rubber dam isolation. Even hydrofluoric acid under rubber dam isolation. So a word of caution regarding air abrasion and hydrofluoric acid. Then the coupling agent. The coupling agent is very simple. Now you don't have to sit down and scratch if I'm going to use a silent coupling agent or I'm going to use a phosphoric coupling agent, because today they put everything in one bottle. Let it be Ultradent, let it be any company in the world, they put it in one bottle. Monobond N is very, very good from Ivoclar, and then you put the composite on top of that. So that is the story. So first thing, in summary, I would like to tell that find out the cause. Without knowing the cause, if you try to do some repair work, it's not going to work out. So please, if my work can also fail, 100%. Even I'm not a god sitting right in front of you. Just because I'm lecturing and right in front of you, that doesn't mean my work is always going to be successful. Not at all. Even my work could fail even after all the precautions what I've taken, but still I have to find out the cause. Then the decision making is very important. If I'm going to repair or replace, please, our patients will accept only once, not second time. So we cannot cut a sorry figure for the second time doing a repair. Not continuously repair, patient lose faith in us. So that critical step of decision making of repair versus replacement is very important. Surface treatment, I already told you, have to do a diamond burr abrasion, then air abrasion, then acid etching. All these possibilities are right in front of us. After that, the coupling agent is very simple. I've not complicated it. And then you put the bonding agent, and then you apply the composite resin and proceed further with the finishing and polishing. So I hope this presentation was helpful in the clinical aspect. Also, you can also contact me in my mail ID drmohanb@yahoo.com, or also follow me at Instagram. Once again, I thank the organizing committee and everybody working there backstage for this beautiful e-conference that has been held today. Thank you so much. And of course, my regards to Dr. Santosh.
Thank you, Dr. Mohan, for a wonderful presentation and throwing so much light on a topic that is not understood very well by a lot of people. And could you elaborate a little bit more about the strength of the hydrofluoric acid and what precautions need to be taken?
Yeah, the strength of the hydrofluoric acid is 5 to 9%. Fine. And if it is glass ceramics Emax, then we etch it for 15 to 20 seconds. If it's a lucite glass, then we move up to 40 to 50 seconds. So that is the duration in which we do. But only thing is that the hydrofluoric acid is slightly poisonous because it contains a fluoride. The fluoride ions get released, and if there are any split tissues, the fluoride can get inside these tissues and cause nerve damage. That is why it is marked poisonous. And in fact, in so many countries, even in Southeast Asia, it's not available for clinical use. They've not given the registration at all. So laboratory does this most of the time. Luckily in India, we have a clinical registration, so this product is available to us. And another thing is that if it touches the dentine, it also chelates the protein. So our dentine substrate will not be very good if it by mistake touches the dentine also. That is why I was very cautious about telling hydrofluoric acid. Please make sure that you apply rubber dam. And I also suggested a clinical tip: do not wash it. I would remove it with cotton and then wash the remnants if at all something is there.
And Dr. Mohan, any role for IvoClean in any of these procedures?
Sir, IvoClean is basically a product which is to get back the surface treatment back. So I get a zirconia bridge from the laboratory and it's sandblasted already. So the minute I try, the saliva contaminates. So probably somebody's asked an Emax laminate to be etched in the laboratory and given to us. And I try it in the patient's mouth, it gets contaminated even under isolation. So the surface treated gets contaminated with salivary proteins, IvoClean would remove them. But here I'm doing the surface treatment by my own. So that means that IvoClean has no role for intraoral.
Got it. Thank you so much, Dr. Mohan, for such a wonderful presentation.
Thank you.
And I thank you on behalf of E-Famdent Organizing Committee and Messi Dusseldorf. Thank you so much.
Thank you so much, sir. Thank you.